So I started looking at this topic with the plan of discussing the data behind various metals and autoimmunity, but ultimately, while I was looking through it, I decided to focus on one of the more substantially studied heavy metals that's associated with autoimmunity, which is mercury. And this is heavily based on a case that we dealt with clinically for about 2 or 3 months earlier this year, for which we got the patient and the patient's mother's permission to go into and are actually publishing as a case report. So what I want to do here is review the history, characteristics of presentations of mercury toxicity in case any learners are on. I know I had to dive deeper into Goldfrank's and some of the other literature in order to refresh myself on how to manage these. I'm going to discuss the case of presumed mercury toxicity leading to an autoimmune presentation, pretty similar to an SLE picture. And then we're going to examine the somewhat limited data behind autoimmunity and mercury exposure. And I have no conflicts of interest. So my starting point for going into the discussion of autoimmunity and heavy metals kind of started with this paper out of the journal Lupus in 1994. Dr. Benghazi had suggested that most of the data due to metal exposure at the time, at least, was for cadmium, gold, mercury, and lithium, with some weaker data showing that maybe chromium and zinc can cause some autoimmune phenomena. With cadmium, they showed in workers that were exposed that it did lead to proteinuria, some interstitial nephritis, and some glomerular damage, but it was unclear if this was really due to autoimmunity. In the in vitro and in vivo animal studies, it showed that it had associations with some changes in cellular immunity, whether that was upregulation or downregulation. And the important takeaway there was they actually found that this varied between different rat species when they used them in animal models. So it started to suggest that there may be some immunogenetic component to the reactivity to these metals. Gold has been used therapeutically for various conditions. And in patients who are treated with gold, it's been associated with some autoimmune thrombocytopenia that's usually reversible when you stop administering the gold, but also has shown associations with glomerulonephritis and with nephrotic syndrome. Similarly, there seems to be some selectivity based on gene expression in those patients as well. And then in mercury, patients have been shown to develop proteinuria, nephrotic syndrome, and in one case, a patient did develop a lichenoid eruption, positive ANA, anti-nuclear antibodies, and a contact allergy to mercury following the exposure. So that'll become a little bit more relevant once we start talking about our case in particular. In 2020, there was a review article that was done in environmental research that looked at the kind of the typical mechanisms of inducing autoimmune disease and then started to apply those to the heavy metals. So the usual way that autoimmune diseases are developed are due to some sort of external stimulus, whether that's a bacterial infection, some sort of viral infection, or a xenobiotic, which includes all of our metals. They found that in susceptible animals, again, that immunogenetic component, metal-induced inflammatory reactions can occur even with low concentration exposures. One of the things that kind of muddies this picture as far as applying it to humans is the idea that there's no specificity that's been clearly delineated between, virus or metal X and autoimmune disease Y. They just seem to see a constellation of changes in the inflammatory process based off of exposure to either an infectious stimulus or a metal. They did find that HLA types, specifically HLA-DR4 and HLA-B27, may actually predispose these patients to being metal sensitive. So overall, the suggestion is that individual sensitivity to metals is based on genotype and phenotypic variations from patient to patient, which will come up a little later when we start looking at the data in certain worker groups in certain areas of the world. In this similar, in that paper later on, they did look at kind of the data behind the various metals and their activities in the immune system. And it seems that some metals may act as immunosuppressants and others may act as immunoadjuvants, so non-specific immune activators. Mercury and lead in their review was shown in vitro and in vivo to induce IL-4 production and dysregulate the balance between your different types of helper T cells, which induces increased production of autoantibodies. They also found that some of these metals may actually induce delayed type 4 hypersensitivity reactions, kind of similar to those seen with poison oak and poison ivy and poison sumac. Overall, though, there are plenty of theories to suggest why some metals might induce autoimmunity, and kind of the prevailing list of those was that they can bind to thiols and modify proteins. We know this to be one of the main mechanisms of mercury toxicity. They may activate B cells and alter your self proteins to induce autoantibodies. They may trigger your T cells specifically to react with native proteins. They've been shown to bind directly in some cases to your major histocompatibility complexes. And then some autoantigens have metal binding sites. And when the metal binds, they can generate free radicals, which can lyse your autoantigens and expose these so-called cryptic epitopes that your immune system usually doesn't see because of the unique nature in which they damage those molecules. So going historically into mercury and the places where we have seen exposures, a big example is Niccolo Paganini, the violin virtuoso in the late 18th and early 19th century. Mercury was used to treat his syphilis, and he ended up exhibiting excessive salivation, erythism, dental decay, and gingivitis. The other major use around that time period was that as a gastric irritant, mercury was used to treat constipation. Another one everybody is probably familiar with is the mercury exposure that happened in hatters. The other name for the outbreak in the 1800s was the Danbury Shakes, named after the tremor that was associated with that toxicity. And that was due to the mercuric nitrate that was used to mat the furs and make the felt on the hats. The Mad Hatter was kind of famously shown in the works based off of Lewis Carroll's work to exhibit some pretty severe erythism with his kind of mercurial personality. Calomel was associated with acrodynia, or so-called pink disease, a painful pink discoloration of the hands and feet when these substances were used for treating either roundworm or teething discomfort. Another famous instance is Minamata Bay with the methyl mercury that was being released by the vinyl chloride plant into the bay, which accumulated in the marine life and then led to some severe neurologic consequences to pregnant mothers who were exposed to too much methyl mercury. Also led to some of the anecdotal stories of cats that were toxic from ingesting those fish parts, who were ataxic to the point that they fell into the water, the so-called suicide cats. And then one of the biggest outbreaks that led to over 400 deaths and upwards of 6,000 hospital admissions was in Iraq in 1971, when methyl mercury was used as a fungicide in seed grain, which was intended to be planted, but instead was ground into bread and consumed by the populace. Nowadays, when we're looking for different sources of mercury, you may rarely find mercury thermometers. They're a little bit more rare at this point, but they still may exist and may be sitting around. Overall, many of our typical sources of mercury are being phased out in favor of other technologies. Occasionally, though, people will get hold of elemental mercury or quicksilver, which is absorbed primarily through inhalation. I specifically remember a jelly jar of mercury that was sitting in my office during my second year, and I assume it's still there in that cabinet. Other sources that we may see more commonly these days include mercury-based preservatives, mercury-tainted seafood, and then artisanal gold mining, which we'll discuss a little bit later. So with the types of mercury exposure, one of the things that was difficult for us to reconcile in treating our patient was we didn't know specifically what type of mercury he was exposed to. In terms of the types, and this may be a review for most people on this call, elemental mercury is absorbed mainly through inhalation. In brave volunteers that were exposed to inhalational mercury, they absorbed somewhere between 75 and 80% of it. Organic mercury is absorbed through ingestion, inhalation, or dermally in the case of one very unlucky scientist in 1997 exposed to dimethylmercury. About 90% of that methylmercury is absorbed inside of your GI tract. And then inorganic mercury, which is, arsenibar or calomel, corrosive sublimate, things like that, those are absorbed mainly orally or dermally, as exhibited by skin lightening ointments and powders. Pharmacokinetically, elemental mercury is going to distribute mainly into your central nervous system and your kidneys. Peak concentrations are actually going to be delayed 2 to 3 days, but they can accumulate significantly after a single acute exposure. They do get converted into a charged cation in the central nervous system, which favors retention there and can make it a little bit difficult to manage the chelation. Organic mercury is a little bit less caustic because of the organification process compared to your inorganic mercuries, and the absorption patterns actually end up being similar to inorganic mercury. Inorganic mercury is going to have high blood levels immediately after exposure, but then it quickly distributes into our other tissues. On the elimination side, elemental and inorganic mercury are going to be excreted through your kidney and GI tract, with a small amount of those volatilizing and being exhaled or leaking out through the skin. And newer data shows that the half-life may extend as far as years to decades, compared to organic mercury, which is going to be eliminated fecally with a half-life of about 70 days. Now, the pathophysiology is relatively well known. There is some more recent data suggesting that maybe selenium has a bigger role than we expected previously. But the main problem here is dysfunction of many different enzymes, membranes, structural proteins, and transport mechanisms, specifically the groups that are containing sulfur and selenium. Can also be associated with generating reactive oxygen species, which can end up depleting your glutathione stores. Most common manifestation that we're usually going to see with most of these mercury exposures is going to be neurologic, and specifically neuronal damage. But we'll find some more clinical effects once we start digging into the immunologic consequences. In terms of your clinical effects, elemental mercury is typically inhaled. So usually patients are presenting with cough, chills, fever, shortness of breath. And then they can, in more severe cases, develop interstitial pneumonitis, ARDS, respiratory failure, and death. Or compare that to organic mercury, which is almost purely neurologic and usually permanent effects on the CNS. Patients may show paresthesias, headache, fatigue, tremor, ataxia, blindness, or dementia. And then in inorganic phases, it acutely acts as a severe irritant and caustic and may cause nausea, vomiting, diarrhea, and then renal failure. But then in subacute or chronic exposures, patients can develop neurologic symptoms, including the tremor and erethism that we classically see, some renal dysfunction, and GI symptoms such as salivating and burning sensation in the mouth. This is the table from Goldfrank's regarding the diagnostics for elemental, inorganic, and organic mercury. Mainstay for what we look at for just exposure ends up being whole blood, and then we monitor chelation using the 24-hour urine in terms of elemental and inorganic mercury exposures. Now, our management typically is decontamination. So first line is making sure you get the patient out of the exposure and ensure the safety of that site. So if a mercury exposure is reported, suspected, or verified in a patient, you have to evacuate that area of exposure. The EPA recommends turning down the temperature and avoiding vacuuming, which unfortunately our patient's mother did not avoid, because that increases the volatility of any mercury that's present. It's then recommended that either the local health department or the fire department get contacted for cleanup. In the case of large volume spills, you also contact the National Response Center hotline. Initial responders will come equipped with NIOSH certified chemical, biological, radiological, nuclear self-containing breathing apparatus and a level 1 protective suit until the environmental concentrations are determined. Aside from environmental decontamination, we remove the patient from the exposure, remove all the clothing, place that in a labeled bag, and then the skin is washed with soap and water, and then they can be transferred to an area where the complete medical evaluation is performed. In terms of chelation, our options are, in the United States, either Suxamur or dimercaprol. Those are shown on the top and bottom on the right. The idea behind the chelating agents is that they have thiol groups that are going to compete for the binding of mercury. We are jumping to those when we have significant mercury exposure history, patient has symptoms, and you demonstrate an elevated whole blood or urine mercury level. Then you consider jumping to chelation. Dimercaprol does have some significant side effects, including nausea, vomiting, headache, and abdominal pain, and it needs to be administered intramuscularly. So Succimer is typically better tolerated. Dimercaprol can be contraindicated in organic mercury toxicity because it may increase mercury mobilization into the brain. And unfortunately, organic mercury patients actually don't really improve with chelation despite lowering mercury levels. They tend to still demonstrate some neurotoxicity that's pretty significant. So the quick overview of mercury, just to jump into our case. So this started off as a very, very vague presentation, as you'll see by the fact that the pediatric service ended up involving essentially everybody in the hospital in his care. So this patient was initially evaluated in February at one of our satellite hospitals, an 11-year-old male transferred for a mild to moderate pericardial effusion, had some respiratory variation that was seen on echocardiogram that was concerning for a possible tamponade. His other symptoms beginning about 6 weeks prior were he developed a rash throughout his chest, abdomen, back, neck, arms, nausea, vomiting, diarrhea, some loss of appetite, and some weight loss. He went on a little later to develop some pleural effusions, but we'll talk a little bit more about that. So in the end, rheumatology, immunology, dermatology, toxicology, renal, and cardiology teams all ended up involved in his workup and care, in addition to a brief stay in the ICU. Ultimately, the suggested diagnosis that was come to by all the services kind of combined was mercury poisoning complicated by a hypocomplementemic urticarial vasculitis, an atypical SLE. The main concern was that it was triggered by the mercury. And when the patient initially presented to the hospital on day one, this was the presentation of his rash, kind of this almost lichenoid presentation to the neck, the chest, the arms, and the back. And the next slide will show exactly what it looked like on day 2. So progressing pretty quickly here. In the course of his workup, he was found to be rhinovirus positive. So another complicating factor in figuring out exactly what his etiology was. He developed a worsening right pleural effusion, which required a chest tube placement, and then he was placed on methylprednisolone pulses, which ended up improving his pleural effusions and improving his rash. Initially, he had that early tamponade physiology on his echocardiogram, but that actually improved with the other supportive care that was here. Rheumatology was brought on board. They recommended all of their inflammatory markers and autoimmune markers. Creatinine actually came back normal. He got an extensive workup, including complement levels, various antibodies, T and NK cell studies, and trended his inflammatory markers, which stayed mildly elevated throughout his course. Initially, his ANA was negative, but when it was repeated a little later on, it came back positive. And like I mentioned, his inflammatory markers remained mildly elevated throughout. Dermatology came on board for this rash. They performed a punch biopsy, which came back showing leukocytoclastic vasculitis, which, if people aren't familiar with that, is a single organ, skin isolated small vessel vasculitis. Typically presents without any systemic signs of vasculitis or glomerulonephritis. The leukocytoclastic portion of this refers to the fact that neutrophils come to the site, they degranulate, and then they degenerate, releasing nuclear debris. The differential diagnosis for something like this includes several drugs, so penicillin, cephalosporins, sulfonamides, phenytoin, and allopurinol, and then several infectious sources, which could be bacterial in the case of things like infected shunts or infected endocarditis, HIV, hepatitis B or C, or various other viruses, or it can be associated with immune complex deposition in the case of autoimmune disease. So in the case that this was related to kind of a paralymphoma type picture, oncology was brought on board and did their magic to rule out lymphoma. Patient was started on a further 3-day burst of IV methylprednisolone. The primary concern for rheumatology at that time was atypical lupus versus a hypocomplementemic urticarial vasculitis. So essentially, he was being treated as a primarily autoimmune skin complaint, separate from the mercury toxicity, which we found out about a little bit later. So on about, I would say, day 14 or so of the presentation, toxicology got involved because the mother reported that her sons, including the patient, were found inside of the garage playing with some form of mercury, presumably liquid, quicksilver, about 3 months prior to his presentation. So once we were consulted and got that story, we recommended blood and urine levels of heavy metals, which returned significantly elevated. He was started on chelation therapy with Succimer on about day 21, which we actually experienced a bit of a delay in the treatment due to a national shortage of Succimer, in which the mother actually ended up having to go to a Walgreens, fill the prescription, and then come back. And the Walgreens was able to somehow source it from a compounding pharmacy nearby. He was also started on selenium and NAC because he had some elevated liver enzymes, which also gave the team pause on starting Succimer. NAC was eventually discontinued after improvement of his liver enzymes. So the description of exactly what happened in that garage was that he and his 2 younger siblings were playing with this mysterious liquid inside of the workshop of the mother's boyfriend. All of them had reported handling the bare liquid. One of the younger siblings later admitted that he had licked it. The mother called her boyfriend after seeing the liquid. He confirmed that it was mercury. But then there were also some unclear reports about her potentially using a vacuum to clean up that spill. In the case of our management, we chose Succimer over dimercaprol, given the unclear species of the mercury that he was exposed to and the potential risk of redistributing further mercury into the brain. Furthermore, he was able to take PO, and the team favored that over the intramuscular administration of a medication like dimercaprol. So this was one of the things that had come up in my research while we were working on this patient's treatment plan, was the utility of selenium in managing mercury toxicity. So selenium has been thought initially as kind of a bit of a reversal, but it seems to be more that selenium helps with selenium depletion in the process of mercury toxicity. So mercury has been described in this review article out of 2018 as binding avidly not only to proteins with sulfur groups and thiol groups, but also selenium-containing proteins, of which there are quite a few in the body. But the conclusion of his review article was that selenium has a multifaceted role with mercury, in that it may facilitate the demethylation of organic mercury into inorganic mercury. It may redistribute mercury to less sensitive target organs. It may bind to inorganic mercury and form an insoluble, stable, inert selenium mercury complex that can be eliminated. It may reduce the absorption from the GI tract, and it may replete selenium stores, which can reverse that selenium deficiency and ultimately restore the target selenoprotein activity and restore intracellular redox environments. So our thought was relatively benign thing that we could give that may help in this patient's case. So given the mercury poisoning in his case, it's thought that the mercury potentially triggered this urticarial vasculitis and this atypical lupus. Ultimately, he was, as I mentioned earlier, chelated, treated with multiple doses of IV methylprednisolone, transitioned over to oral steroids, was also started on some steroid-sparing agents for rheumatologic treatment, including hydroxychloroquine and mycophenolate. So ultimately was discharged with a plan for weekly methylprednisolone infusions, going home on prednisone daily, along with the other steroid-sparing agents. During the course of his hospital stay, his rash improved dramatically. This was on day 11 after he'd been started on some steroids. You can see them actually prepping for the chest tube for his pleural effusion. And ultimately came back looking something like this. During the course of his stay, there was a concern for a potential allergic reaction to the Succimer, but he never had any airway involvement, instability, or other signs of anaphylaxis. So he was given IV Benadryl prior to his subsequent doses, and then was ultimately transitioned over to oral Benadryl, but then developed some hives along with wheezing, so he needed albuterol after his second dose of Succimer. immunology came on board, and they had low concern for an IgE-mediated reaction. So they switched him over to cetirizine, 10 milligrams BID, and he had no further issues with the succimer that he was given. His first round of chelation finished probably about 6 weeks after his initial presentation. The selenium was shortly afterwards discontinued. Repeat mercury was elevated from prior, kind of jumped back up, and he ended up being discharged on 2 weeks of oral succimer therapy with repeat urine mercury levels afterwards. This was the trend of his blood mercury concentrations throughout the course of his chelation. And ultimately, he ended up improving pretty significantly after discharge. And the last note that I was able to find was somebody trying to reschedule one of his methylprednisolone bursts. So he must have been doing well enough that he and his family felt they could kind of ignore that appointment. So looking into the evidence behind mercury exposure and autoimmunity, I found this paper from 2017 in Autoimmunity Reviews by Dr. Crow and his colleagues that looked at not only healthy participants that had been exposed to mercury, but then also mercury exposure in autoimmune patients. So as you can see by the results column on the right, maybe a little bit difficult to read, but the data varies significantly. Some of the case series that we report here show a higher ANA, some show some correlating immune function changes, some show no difference at all. But those were in otherwise healthy participants who were exposed. One of the things that I think may be confounding some of the changes in these data are the locations in which these were performed, because we've seen that there's some immunogenetic variation, at least in mice, between whether or not they actually have a response to these heavy metals. A few other points from this paper, they did mention that rat studies showed that SLE could develop from inorganic mercury exposures in rats, but not in mice. So there's more species and genetic variation in response. Inorganic mercury was shown to have more association with pro-inflammatory processes than methyl mercury was. But overall, it seems that inorganic mercury may actually perpetuate a lot of markers of autoimmunity, if not lead to an autoimmune state. Excuse me. And when they looked at autoimmune patients and their mercury exposure, they showed correlations in some cases, not necessarily causation, but correlation in the cases of thyroglobulin antibodies, patients with Kawasaki disease, and patients who presented with pemphigus. Again, we know from prior data that dental amalgams were not shown to have an effect, and this review again showed the lack of true mercury toxicity from dental amalgams. In terms of inorganic mercury, a study on industrial emissions effect on autoimmunity showed a higher prevalence of SLE compared to those in a controlled area. And then 3 out of 4 studies which have investigated autoimmune parameters in gold miners who are exposed to significant amounts of mercury reported that the concentrations of anti-nuclear and anti-nucleolar antibodies were higher in gold miners compared to controls. So it seems that inorganic mercury exposures and high total body mercury are both associated more with autoimmunity. Organic mercury, on the other hand, actually appears to show a little bit of an immunosuppressive effect. And then again, the authors reference the genetic components that likely play a role in these metal-induced autoimmune diseases. This review article from 2005 looked at specifically the mechanisms of autoantibody formation with various metals. The problem that they ran into with a lot of the in vitro studies is that there are a lot of different cells, a lot of different immune markers and immune mediators that are involved in the immune response, which leads to the idea that seems pretty obvious that these effects are better studied in vivo than in vitro. So they found if you disrupt interactions between your T cells and your antigen-presenting complexes, you actually don't generate autoimmunity in rats who are treated with mercury, compared to those that were not disrupted. So that suggests that there's a pretty typical T cell mediated immune response to mercury that's happening in those rats. Mercury treated mice were shown to have higher levels of IgG and IgE levels that peaked at about 3 weeks after exposure. Again, the mouse studies and rat studies showed some differing responses depending on the specific rat or mouse strain that was used, which again highlights that genetic susceptibility. Another really interesting finding that I referenced earlier on was cells that died from mercury had produced unique fibrillary cleaving fragments that the immune system potentially could identify as foreign because they're not the typical epitopes that are displayed to the immune system. So in conjunction with the right genotype and the right expression of certain major histocompatibility complexes, those cleavage fragments can lead to autoimmunity. And then this manuscript that eventually did go on to get published by Dr. Pollard and his colleagues showed in more human data that was reviewed, elevated serum levels of various inflammatory markers, including IL-1 beta, TNF alpha, IFN gamma, that were found in gold miners in Amazonian Brazil. So that's dealing with a specific geographical area and probably a pretty specific population. They also found among fish consumers in the same area in the Amazon increased levels of IL-17, IL-4, IFN gamma, and L6 associated with increased mercury exposure from the fish they were consuming. They found in patients that had much, much smaller exposures than those two groups, those were not associated with increased cytokine levels, which suggests either some difference in their genetic profile or a potential dose response curve as far as mercury and autoimmunity is concerned. So while the evidence of clinical disease remains pretty elusive, mercury exposure in humans has been linked to the presence of autoantibodies. Problem is, some of the groups that are studied are not generalizable to the major population because we're dealing with specific genetic populations that would have different results if there was an immunogenetic component to this disease process. So all of that to say, several heavy metals have shown associations with autoimmune diseases, including gold, mercury, lithium, and cadmium. The mechanism of autoimmunity, while it's been dabbled in by a lot of different people, is not well understood, and there are a lot of theories behind why you may actually induce autoimmunity due to mercury or other metals. Correlations between specific disease entities and specific metals have not definitively been made. And in cases that are studied, kind of similar to the case I presented earlier, there are a lot of kind of confounding factors that may lead to an autoimmune presentation independent of mercury. Mercury has, however, been shown to induce production of those inflammatory processes with an immunogenic bias. And further studies would be needed to help elucidate the effect of chelation on the severity of autoimmune disease. I wasn't able to find any specific data suggesting that the autoimmune disease actually is improved by chelation of the substance that they were exposed to. All I can hypothesize is we had a patient that showed up with a pretty severe autoimmune disease and a concomitant mercury exposure, and his rebounds in his urticarial vasculitis seemed to improve after chelation therapy and after an improvement in his body mercury levels. So a lot of hypothesis, not a lot of definitive conclusions for that. I apologize, but I think it's interesting that there's such strong, at least animal data on the development of cytokines in the face of heavy metals. And then here are my references, and I'm happy to move to any questions that I might be able to take a stab at.
Alex, thank you so much. That was really, really interesting. Thanks for sharing that with us. So I don't see any questions.
I have a question.
There you go, Bob. Go ahead, Bob.
Alex, thank you. That was wonderful. I remember reading the Rick Spiller paper about selenium and also seeing a presentation about that. And I seem to remember that it was mostly hypothesis generating and that there weren't a lot of data to actually support those theories. And I'm totally okay with giving a small dose of selenium to anybody. And I think that's not an unreasonable thing to do. But I'm wondering if you would just comment on how strong a recommendation you think that is, or how tight you think the pathophysiology really is.
The only data that I was able to see that he specifically referenced inside of that paper was when he was discussing the in vitro binding of mercury to selenium-containing proteins, in which he stated that it was, several degrees of magnitude higher in terms of binding compared to the sulfur-containing ones. So agreed completely. It was totally hypothesis-driven. And that was the only data that I was able to really find. The theory behind the selenium depletion in the body seemed strong enough to me at the time that we made the recommendation. And at the Children's Hospital, they don't typically push back against what we or the Poison Center do say. Very often, they're pretty happy to hand over the reins to us from that. So we made our recommendation without necessarily a super strong degree of force, and it was followed without any untoward consequences that I can see. So the list of effects of selenium was, I agree, a total hypothesis, but we figured it was worth a try.
Hey, Alex, it's Marianne. Nice to see and hear you. Very interesting presentation. I have a couple questions. Did you do any HLA typing on this patient?
I have to imagine they did. In digging through the chart, it was several months worth of data. So I would have to look back to see if they actually got the specific HLA types back from the rheumatologic side.
Be kind of interesting. And he didn't have any autoimmune disease his family history or SLE or anything like that?
No known family history that he presented with. It was kind of a shock to the family overall.
And how about the siblings?
So the siblings and the mother actually were recommended to come in. They never actually presented, as far as I'm aware, to be evaluated for potential mercury toxicity.
Interesting.
And then the report that I got, while it was brief, from the cleanup crew that went there, said that there were astronomical levels of mercury inside of that garage.
And how about in his room? Do you think he brought stuff back to his room?
It's potential that they could. They didn't mention that to us in any of the communications that we had. And the story said that it was pretty limited to the garage, which is obviously where the mom found them and then presumably cleaned them up. But I didn't directly get that portion of the story from the mother. That was one of my colleagues.
Yeah, very interesting. Thank you.
Alex, I'm sorry I missed or I forgot the presentation of this kid. So did the kid actually have elevated mercury concentrations?
So he did, yes. His mercury concentrations initially were above the level that the lab was willing to report. And then his urine mercury concentrations, while he was being chelated, given that's not great data, remained elevated above the level of the maximum level of detection of our labs.
Right. So if we see patients who present with and we suspect an autoimmune disorder, should I be testing for mercury?
I think in the case of a concerning exposure or potentially a family member who is in an occupation that would put him at risk, I would. Otherwise, it seems more like you're on a fishing expedition. So in this case, we were lucky enough to get the history of mercury exposure and then go down this rabbit hole. Whether or not the kid would have been fine with just the rheumatologic interventions that were being performed, I don't think we'll ever know. But in taking out one of the potential causes, I think we gave the kid the best chance to live a normal life. So in the case where somebody comes in saying, my cousin is an artisanal gold miner or my dad keeps mercury in the garage, then I think that's a case where you might think about checking levels.
And aside from the elevated mercury concentration that you show here, was there anything else on the laboratory test that would be suggestive of mercury in the absence of this level?
So he actually had normal renal function. His other heavy metals were actually normal as well. So it was kind of an isolated elevated mercury concentration.
I see. Okay, yeah, thank you. Thank you very much.
Alex, you learned a lot, and it's helpful to think about all these issues. And the question is, I guess, we've always thought about this, but I guess we come away with it remains a possibility. It's a very infrequent condition in a young child, and he's got a disorder that you're able to eliminate some of the mercury, and what goes on, you would expect to continue if it were the stimulus, because the concentration in his body is going to stay pretty much the same as it started, right?
Sure. Yeah, I mean, the only anecdote that I can think of is that, we got some small amounts of the mercury out, and he seemed to not have as many, relapses into his urticarial vasculitis as before. And, that's not data, that's a correlation, and it may not be a very strong one, but makes me feel pretty good about us at least having tried something for him.
Yes. I mean, I guess you had resolution of the vasculitis to some extent after the various bursts of high-dose steroids initially.
Right. His initial methylpred bursts had initially controlled and improved the rash, and then it kind of relapsed during the course of his hospital admission while the chelation was happening.
Well, it remains, I guess you had to do some public health education for the boyfriend of the wife. There are probably other things in the back cabinet for this guy.
Absolutely. And yeah, the family was counseled about the safe storage practices of various materials they probably shouldn't have kids access to. And then one of the focuses of the case report that we're going to come out with is going to also be the decontamination of sites of exposure for heavy metals. So hopefully that'll help at least get the word out amongst the pediatric colleagues that we're dealing with.
What was he using the mercury for?
He was a little squirrely about that, so I'm not completely sure exactly what he was using it for.
I don't know. Yeah.
There was a little bit of a social component to this case with regards to the mother, the boyfriend, and their willingness to cooperate with some of the questioning.
So, of what illicit value is mercury?
I mean, it looks cool. Otherwise, I'm not really sure what specifically he was using it for. If it was just something that he thought was aesthetically pleasing, I couldn't tell you what the illicit value is. I didn't really look too deep into how it's being used in potential street pharmacology. If anybody else knows what it's specifically being used for, I would love for them to chime in.
We don't have any thoughts from anybody? Bob or Silas? Some obscure link?
Yeah, I'm striking out on this one.
Yeah. I don't see YJ Sue isn't on the line. I looked, so they're not. I mean, it's strange, obviously, in the climate. I don't know what benefit of that is to use around the house, unless he's a chemistry professor and doing something silly, or he was using it to poison people.
One thing that just a theory or guess as to uses of mercury is that mercury has some anti-infectious, or thought to have some anti-infectious properties. I don't know, anti-COVID something therapy, perhaps. I'm just throwing a stab in the dark.
Yeah, that certainly could be if he was following along with like kind of the mercury along with the copper and all those other like copper lime surface type theories. Yeah, very, very possible. My prevailing theory is that he just thought of it the same way that I did when I was a tox fellow, in that, oh, cool, I have a jar of mercury.
Yeah. Well, it led everybody to think about mercury in Texas, and so it's valuable to reflect on it. I mean, it sounds like at least a very uncommon clinical presentation for a young child. He was significantly overweight. That wasn't from steroid use, his breast or the size of his chest.
Yeah, he baseline had some obesity. He did, over the course of follow-up visits, they documented Cushingoid features because of all of the steroids that he eventually was on. But yeah, baseline, he was a little bit overweight.
Okay, well, shows you learned your style of investigation from your experience with us, and appreciate it a great deal.
Thank you for having me.
Yeah, thanks a lot, Alex. Okay, so we're gonna take a little break and we'll come back at 2 o'clock for a consultants conference. So we'll take a little break. Thank you.